Aloha mai kako. Hui Aina Pilipili is a Native Hawaiian initiative in the College of Social Sciences at the University of Hawaii at Manoa. Pilipili marks the Ili Aina, a subdivision of land where we are located on the Manoa campus. Our initiative provides a coordinated effort in the College of Social Sciences towards becoming a Hawaiian place of learning. Pili I Ke Kanaka is our Indigenous Speakers series that features Native Hawaiian and Indigenous scholars, practitioners, and leaders on social science topics. Through this speaker series, we hope to build pilina, relations, through the engagement of students, staff, faculty, and the community with thought-provoking social science knowledge from Indigenous perspectives. Aloha mai kako. Mahalo for joining us today for our Pili I Ke Kanaka Indigenous Speaker Series. The speaker series is part of Hui Aina Pilipili, the Native Hawaiian initiative in the College of Social Sciences here at the University of Hawaii at Manoa. I am Komokana Aquino, the coordinator for Hui Aina Pilipili. Hui Aina Pilipili provides a coordinated effort here in the College of Social Sciences towards becoming a Hawaiian place of learning under the University of Hawaii at Manoa's commitment to Native Hawaiians and Hawaiian knowledge. Our mission here is to strengthen Ea Hawaii in the social sciences through Hawaiian-centered teaching, learning, service, and scholarship, while cultivating pilina, relations, and kuleana, responsibility, with students, aina, and communities to strengthen our lahui in Hawaii. Our Pili I Ke Kanaka Indigenous Speaker Series features Native Hawaiian and Indigenous scholars, practitioners, and leaders on related social science topics and connects and engages students, staff, faculty, and community with thought-provoking social science knowledge from Indigenous perspectives. Today we have Dr. Keaweʻaimoku Kaholokula, who is a professor and chair of the Department of Native Hawaiian Health in the John A. Burns School of Medicine here at the University of Hawaii at Manoa. He is a licensed clinical psychologist and a graduate of our psychology program, receiving his bachelor's, master's, and doctorate all in psychology. Dr. Kaholokula is a translational behavioral scientist who has led multiple federally funded research projects aimed at explaining, preventing, or treating cardiometabolic-related medical conditions in Native Hawaiians and Pacific Islanders to achieve health equity. He is a co-principal investigator for the Pacific Innovations Knowledge and Opportunities, PICO, Clinical and Translational Research Center. Along with colleagues, he has developed national and international research training programs to support Native Hawaiian, Pacific Islander, and other science underrepresented students, postdoctoral fellows, and junior faculty in pursuing a health science research career. Dr. Kaholokula has published over 140 scientific and academic publications and has made and continue to make an impact on the local, regional, national, and international levels to bring systemic improvements to healthcare delivery, clinical outcomes, and policy. Here in Hawaii, he has served on several boards such as the Queen's Health Systems, the Hawaii Public Health Institute, and Papa'ololokahi, the Native Hawaiian Health Board. On a national level, he is a past chair for the Intervention Research to Improve Native American Health Network, current co-chair for the Asian American, Native Hawaiian, and Pacific Islander Special Interest Group of the Community Engagement Alliance, and was appointed to the National Advisory Council on Minority Health and Health Disparities. Dr. Kaholokula is also a co-lead of the Native Hawaiian and Pacific Islander COVID-19 Response, Recovery, Resilience Team for Hawaii. He is passionate about improving the health of Native Hawaiians and Pacific Islanders and made a lifelong commitment to improving their social and cultural determinants of health. I'd like to welcome Dr. Keaweʻaimoku Kaholokula. Mahalo for joining us.
Mahalo nui, kamakana. Mahalo for that introduction, and mahalo to Hui'aina Pilipili for the invite to participate in this lecture series for Indigenous scholars. I'll be sharing with you one of the projects that myself and my team have been working on with community partners across this Pai'aina for the last, I would say, 11 years now. And it's really, you'll see why it's been 11 years to develop and really test the effects of what is probably the first project of its kind that has taken an indigenous practice, leveraged that for health promotion, and tested it scientifically, but doing so with close collaborations with community partners. In fact, our community partners were actually the ones who delivered, evaluated, and so forth the intervention. I'll explain more as we go along. Title of my talk is Using a Native Hawaiian Cultural Practice to Prevent Cardiovascular Disease, the Kaholokula Project. And I want to start off by recognizing the large team we have, both academic and community advisors, investigators, and partners across 3 islands, Hawaii Island, Maui, and Oahu. And you can see their names here. I won't go all over every single one, but I just want to highlight Mapuana de Silva, Kumuhula of Halau, Mohala Ilima, who is really the Hula cultural expert for our project for the last 11 years, and helped work with other kumu across the state in designing and really testing this intervention that would ultimately address cardiovascular disease risk in Native Hawaiians and all of our community partners. And so just going to give you a background to why it was important for us to develop a culturally grounded approach to addressing a serious medical condition in Native Hawaiians. So hypertension or high blood pressure is a major risk factor for heart disease and stroke, basically cardiovascular disease. And Native Hawaiians, as well as other Pacific Islanders, when we compare them to whites, are 75% more likely to have high blood pressure. We're also less likely to receive adequate hypertension treatment. We're also about 4 times more likely to develop heart disease and stroke as a result of having high blood pressure uncontrolled. And we also develop cardiovascular disease a decade sooner than other ethnic groups here in Hawaii. So it's a real big issue, and it's been a challenge for us to find sustainable and relevant ways to address the issue of high blood pressure in our communities so that we can reduce the risk of cardiovascular disease and early death across the different Native Hawaiian Pacific Islander communities. And to give you more of a background, often to address high blood pressure, we focus on one area is physical activity, getting people more active, getting more exercise, basically. The other thing that we also focus on is dietary changes, eating healthier, in particular, addressing our salt intake, reducing that, so that we can better manage our hypertension. But focusing on physical activity, because Hula really is more of a is basically a physical activity intervention that we were thinking of at the time. Other studies have shown that physical activity can significantly reduce the risk of heart disease in other populations. So we thought, well, maybe we should look into whether or not we could use one of our cultural practices that is a type of physical activity and see if we can leverage that to address the issue of hypertension and cardiovascular disease. And one of the things we were doing at the time, about over a decade ago, is talking with different members of our communities, Native Hawaiian patients, and really asking them, what would they like to see in a health promotion program if we were to offer something or design something? And what are your thoughts about healthcare in general? And what we were learning is that there's a tremendous distrust towards Western medicine for many reasons. We see that playing out now with COVID-19 and the hesitation around the vaccination in our communities, but there is a tremendous distrust there. And what they were saying was we needed to have strategies to health promotion that were more in line with our cultural and spiritual values. A lot of the things we're asked to do don't make sense. It also doesn't match our economic circumstances, in which we just don't have the time, having to work several jobs, make ends meet. It just wasn't realistic. It wasn't enjoyable or sustainable. Nobody wants to go on a treadmill, walking in place for 30, 40 minutes every day. It's boring, right? So they were asking for things that really made sense and that were part of their natural world, or they're things they could do naturally and enjoy. And we were thinking about culturally grounded approaches. Often in our field, when we look at health promotion and we design or develop interventions, often we take interventions that were actually designed for other populations, and then we culturally adapt them to make them somehow relevant or fit our local context or our communities. But still, that's really taking something fundamentally different or fundamentally of value to another group and making it try to fit, our situation and context. The other approach is really developing culturally grounded approaches, really from the ground up, where the cultural practice, values, or perspectives are really the core of the intervention itself, rather than some other foreign or some other curriculum. And so we really began this process again over a decade ago, working with Kumuhula Mapuana de Silva, and we were looking into whether or not hula could be leveraged as a health promotion strategy. Why hula? Well, hula is one of our most popular cultural practices. It's very visible. It's pretty much available in all communities. So talk about sustainability after it's done. This is something that we all can do. It's available to us. And it's just attractive to so many people, not just Native Hawaiians, but people of other backgrounds. And as we know, there's probably more halau hula outside of Hawaii than in Hawaii, such as in Japan, Mexico, and even in Europe. So it's a really popular cultural practice, especially amongst our own people. The other thing about hula, that it lends itself to adjusting the tempo, the intensity, right? So if you're in your teens, you're in your 20s, and you're ready for Mary Monarch, you can do the duck walks all day, go up and down, ka'i and ho'i, really easy. That's high intensity, right? And we know if you dance hula and competitively, that is pretty rigorous. And for the 5 minutes you dance, it feels like you ran 2 miles, right? And then there is the kind of hula we can do with our kupuna, side to side, kaholo, noho, and other things. And we can adjust the tempo, the speed, and everything. But also it has some meaning to us, yeah, lots of meaning to us. It's a way to preserve our language, connect to our history, connect to each other, transfer our cultural knowledges, connect to our environment and everything else. So it really is something that we thought was a complete package. Because when you think about addressing hypertension, it's not just diet, it's just not physical activity, it's also stress. And we're under a lot of stress, economic stress, and so forth, chronic stress. So it's also all these things. It's about social connections that we can make through hula, the cultural connections, feeling valued, and doing something we enjoy, all at the same time while getting physical activity. So I really thought it was a complete package. And so in order to really do this right, we wanted to really engage our communities. So over a decade ago, the first thing we did was engage the Kumu Hula community, because they are the keeper of this tradition. We wanted to make sure it was appropriate. We wanted to make sure we did this right. Again, our goal was not to hula-size hula, right, or change it up to fit some other situation or circumstance. We wanted hula to be done with the cultural integrity, and same way you would do it in a halau, right, with the cultural lessons, the language, and everything. So we wanted to make sure it's done right. So we did extensive interviews and meetings with various kumu hula across the Pai'aina to get their thoughts, to get their blessings, to proceed and do this and engage them in the process. We established a research team and advisory group that balanced the cultural expertise we needed. So we had other kumu hula to advise us, to make sure we had that expertise and wisdom. We also engaged medical experts. So aside from myself, clinical psychologist, we got a cardiologist, Dr. Todd Sito from the Queen's Health Systems, and we got some national experts to help guide us in this process. And then we needed to determine the cultural relevance of using hula to address heart disease, hypertension in our communities. So we actually met with Native Hawaiian patients and their families who were living with hypertension and or heart disease. And we wanted to get their thoughts about whether or not hula was something they would be interested in, something that made sense to them, and what value did they see in that. And the great news is that everything that the Hawaiian patients and their families were saying aligned very nicely with what the kumu hula were saying about the value. And we know hula has a tradition of health and well-being if you go back to Kawaka Hiko, yeah? So it was already in our culture, and people today, our communities really felt it was still relevant. And what they were all saying was, you know, hula, unlike other types of physical activity that you're asked to do to manage your health and well-being, is that it has a spiritual, cultural, emotional, social, and physical connection and level that you just don't get in jogging. You just don't get going to the gym. You just don't get when you just make, you know, these get on a treadmill at home or whatever it may be. Yeah. So we went ahead and developed and tested initially the feasibility of doing a hula intervention. And Kumu Mapuana was great. She has a physical activity, physical education background as well. So she really understood. She designed the hula. We tested it. For the sake of time, I can't go through everything we did, but we did a lot of things just to get to what I'm presenting to you. So what I'm going to present to you is really the last 5 years of our work over the last 11 years of work to get to that point and being able to really definitively test the effects of a hula intervention. So we had 3 aims for our study that was funded by the National Institutes of Health, and it was for 5 years. The first aim was really to compare basically how effective was our intervention, our hula intervention, which was 6 months long, compared to a waitlist control group. So the waitlist control group is people who are basically exactly waiting on the list to get the intervention after the first group is done, and they become the control group, right? To compare to a group of people who did not receive the intervention. This is kind of the gold standard in science to test the effectiveness of interventions. But rather than do a straight control group, we decided that we wanted to offer the intervention afterwards so that they didn't miss out. And aim 2 was to really look at whether or not just did we improve their blood pressure in Native Hawaiians with hypertension, but whether or not we could actually reduce their 10-year risk for developing heart disease down the road. And there's actually validated risk scores that you can use based on people's current blood pressure, whether they smoke or not, do they have diabetes, their cholesterol levels, and can actually give you a risk percentage of the chances of you developing heart disease down the road, given all of your current health profiles. And it's been well validated. It's actually used in clinical practice to help counsel and work with patients. And then the aim 3, I won't cover here for the sake of time, but we basically want to know, how does our intervention actually work? So Olohoi Kahula is actually the name of the intervention. Kaholo is the overall program or project. Olohoi Kahula is the name of our intervention. That's Mapuana de Silva there on the left with the ukulele. Mele Look is one of the investigators in the pink on the right. This is from, we got permission, by the way, to use these photos. These are some of our classes and some of the projects we've been working. The bottom left there is one of our community, the left is one of our community organizations that participate. And who are these community organizations? So as I mentioned, we had sites on Hawaii Island, Maui, and Oahu. These are the organizations. We had Kulonanapo'e Hawaii, which serves the homesteads community of Papakolea, Kalavahina, and Kewalu. We had Iololahu, a behavioral health program, Waianae Coast Camp, a community health center, Ke'olomamo, the Native Hawaiian healthcare system on Oahu, Hui no Ke'olopono, the Native Hawaiian healthcare system on Maui, and an organization called Mauliola on Hawaii Island. So we actually were recruiting and working with Native Hawaiian communities across these different areas to ensure that we had good representation. And so what we did was so who were eligible to participate? They needed to be Native Hawaiian with a physician diagnosed hypertension or high blood pressure. They needed to have no heart disease or stroke, because remember, we're trying to prevent heart disease. In order for us to understand that, we kind of have to start with no disease yet, just the hypertension, yeah? And what is uncontrolled? Uncontrolled hypertension was basically, there's the systolic blood pressure, which is the number usually above, right? And there's the diastolic blood pressure, usually a lower number, which is on the bottom. And so the systolic blood pressure needed to be 140 or higher, meaning that they have hypertension, but it's not well controlled, because at the time we started this study, the clinical recommendation was to have it under 140. So our goal was to get them under 140 controlled. And then, of course, there's other things that needed to be 18 years and older and so forth. And then, as you can see, we were able to identify 263 Native Hawaiians who were eligible across the 3 islands I shared with you earlier in the organizations, they all got a basic heart education, like culturally informed, basically the learning about the type of diet, low sodium diet one should be doing in order to manage the hypertension, the value and why physical activity is important, but also stress management, because there is a stress component to blood pressure. So everyone received this. This is a basics education. This is above and beyond what you would probably get as standard care at a clinic. And then they were randomized to either receive Olohoi Kahula immediately, or they were put into the waitlist, the education-only waitlist control. And then, of course, after at the end, they were offered the intervention if they so desired. So you can see they were equally randomized, 132 into control, 131 into our Hula program. And they went through the first, there was basically 2 phases of our Hula. The first phase is 3 months, exclusively Hula, 2 times a week, 60 minutes each time for the entire 3 months. Then they went into a maintenance phase because in our initial study that we did, the pilot, we found that our 3 months led to significant improvements in blood pressure, but after the intervention was done, it started to go back up. So we wanted to make sure there was a maintenance to help people make this part of their lives so that it can be sustained, right? And so we added additional 6 months to this definitive testing, in which there was continued Hula with the kumu in their community, but we also did other activities to help them develop a healthy lifestyle plan that was realistic for them, that accounted for their life circumstances, that they could do, give them time to do it, get feedback on it, share with each other. So there was a lot of interaction with each other, the participants. There was interaction with our community health workers who were trained on some of these protocols and offering support. And then after 6 months was done, we left them alone, and then we reassessed them 12 months later. So the education, the control group and the Hula group all got a baseline assessment, got 3 months, 6 months, and then for the intervention group, we followed up 12 months later to see how they were doing. Were they able to maintain any improvements? I just want to highlight that right here, we see, we want to note that we had excellent retention, which really spoke to how much our participants enjoyed our project and the Hula, because to have a 91.6% retention and 87% eventually over time is unheard of for a clinical trial of this type in populations considered high risk. So this is actually, that was something we saw very positive. So kind of give you an idea of what the participants went through. Olohoi Kahula first 3 months, as I mentioned before, is just with the kumu twice a week, 60 minutes each. What you see there in the box is really what they went through, right? We had a warm up, because for safety reasons, we want to make sure people stretch. We had kupuna and so forth. They had to go through this, and this part was standardized. Conditioning was really the Hula. It started off for 20 minutes, but we slowly got up to 40 minutes of intensity. And the type of Hula, the intensity, the speed by which they did it, and so forth, changed over time to get longer and more intense. And we also collected information about their blood pressure throughout to make sure they were getting up to their working heart rate, to make sure they were getting to the place that would benefit them as far as national recommendations for physical activity. And we always ensure we had a cool down for safety and make sure people was left our sessions okay. This was all delivered by a kumu hula from the community that we were in. So we wanted to develop capacity and really utilize local talent and expertise and make sure for sustainability. And the goal of each hula class was again to increase over time the minutes of continuous dancing. And then the latter 3 months that I explained, which was really the maintenance phase, kind of give you an idea of what we did here. Makahanakaike was kind of what we called it, right? Is in doing that we learned or become experts on acquiring those skills and knowledge. So this was really a time for them to practice, put into practice into their regular lives. So we had goal setting exercises, was individualized for each person because everybody's different. We talked about worksheets around values and time management, make sure that could help people better manage their time, work through some things, connect the values to the behaviors they were doing and the changes they were making. We also reviewed materials around managing their hypertension, sodium reduction, and so forth, but maintaining the hula and these various activities for the remaining 3 months. Now, who were the participants that were in? We had 263, as I mentioned, 131 received the intervention. Majority were female. This is not unusual for most research in general, but especially in our communities. More Wahine are interested in giving of their time for research activities. Average age was 58 years, or 45% of them, half nearly, had diabetes. 86% of them, although all of them were under physician care, and at least for the previous 6 months of starting our study, 86% were on medication for their blood pressure. But despite this, it was still not controlled. So they're under physician care. They're getting medication for their hypertension, but yet they're not reaching the goal for management. 73% had dance experience before, but this could have been like Mayday, young kid days. It wasn't. We didn't go into whether this was very monarch kind. Average starting blood pressure at baseline was 44/85. So as you can see, above, not controlled on average. It was pretty much the same for both groups, but everything was balanced nicely across the control and the intervention group. Now here are the results. So our goal was to actually focus on systolic blood pressure, reducing that, again, under 140, right? And what you see here on the left is Olohoi Kahula, which is the results for the Hula. And on the right, the blue, is basically education control only. As you can see, all of them started at baseline at pretty much 144, 145. That's not significantly different. That's well balanced. And then after 3 months, our Hula group actually went down 2 stages. So there's several stages of hypertension, and the stages go up in severity, right? First, you're elevated, it's getting up there. Caution, you got to do something. Stage 1, you got hypertension, but it's not that high yet. Stage 2, and so forth. So as you can see, everyone started in stage 2, and for our Oloho, in 3 months, a matter of 3 months, they fell under, on average, under 2 stages, under 130. Whereas it didn't quite get that far for the education only group. Remember, they received education, so you would expect them to improve their hypertension management, not to the degree you would expect the intervention group to, right? So we do see an improvement, but it doesn't quite get down to where it's at. And that's a statistically significantly different from each other, as well as 6 months. And in fact, at 6 months, one can say that there's no further improvements at all, whereas with the Olohoi Kahula, continuing to participate actually did reduce their blood pressures even further on average. And when we look at the percentage of participants who actually became controlled, so that means the number of them who went under, so we even went further than 140. We went to the new standard at the time. So when we started this, 140 was the target, and some new guidelines came out during the study. So we went ahead and looked at the new guidelines, which are more stringent, which is under 130 over 80. We said, well, how many of our participants reached that goal, which is much harder than the 140, right? So 43% of our intervention folks got under 130 over 80. So a lot of them got below 140, but 43% went even further. Whereas the control, 21% got there, and that was statistically significant from each other. So that means that our intervention had a significant effect on our participants. Now, what about the cardiovascular disease risk factors for 10 years out? I mentioned that there are these formulas or these calculations we can do. The Framingham CVD risk scores is a popular one. It's used a lot in clinical settings. It has been examined across different ethnic groups. Just FYI, there has been no normative data on any of these for Native Hawaiians, and very few for Indigenous people in general. So we used the best ones we thought were the best at the time that we could get to look at the risk. It accounts for different things such as the age of the person, their gender, systolic blood pressure, their cholesterol level, whether they smoke or not, diabetes status, and whether they're being treated for hypertension. And when you enter all of this into the model, it gives you a percentage or a score, the risk score. And so what we found basically was those who underwent the Hula intervention, their risk reduction, we had a 5.2% risk reduction overall compared to only 2.6 in the control. And this was statistically significant. So there was a strong effect in reducing the overall risk for cardiovascular disease over 10 years based on this risk score calculations. And at 1 year follow-up, so after they completed the intervention, 6 months later, 1 year after starting our study initially, we went back and reassessed. Of course, we took clinical measures, blood pressure, cholesterol. We took social cultural assessments. We had even a measure around connectedness to nature. At the time, we didn't have something comparable to looking at the relationship with Aina, but we found something that was used with American Indians it was talking about connection to nature and land. We did a host of things, but for the sake of time, I can't present that. But what I can say is that 1 year follow-up, those improvements we saw were actually maintained, if not in many areas, slightly more improved at 12 months. This is 6 months after the cessation of the intervention itself. But I do want to note that many of them did go on to join a halal or continue to dance hula and had an action plan to continue other forms of physical activity, which was the goal. Whereas they continue to improve. So conclusion, basically, when we look at the big picture and compare this to other interventions, non-pharmacological interventions for hypertension, how well does hula do, right? So on the right there, you can see hula is pretty good. Actually, compared to others, it may be the best non-pharmacological intervention. When we look at just healthy diet change, the DASH diet's a popular one to reduce sodium, get a lot of fruit and vegetables and fiber and so forth. It drops an average of about 11, the systolic blood pressure. When you reduce just sodium alone, it's 5 to 6 on average. If you get weight loss, it drops 5 on average. If you address alcohol, which contributes to blood pressure, it drops 4 average. If you just look at other regular physical activities, such as walking more, jogging perhaps, it's anywhere between 5 to 8, it drops in systolic blood pressure. We saw 15 from the point of baseline to this end of 6 months. On average, a 15 point drop in their systolic blood pressure. So our conclusion is that hula intervention did improve the blood pressure and cardiovascular disease risk above and beyond that of just self-care education alone in Native Hawaiians who were once uncontrolled in the hypertension. Exercise outcome expectation and medical adherence, we found to be some of the mediators in that, in which our intervention somehow helped to improve these factors, which helped to also lead to further improvements in blood pressure. We effectively implemented this cultural-based intervention across different community and clinical settings. Again, we had a homestay community doing this. We had community clinics, right? We had Native Hawaiian healthcare systems, and so forth. So this can be delivered and implemented in various settings using various levels of existing resources. Outstanding recruitment and retention rates. This is unheard of. I've done other similar control trials in Native Hawaiians over the years. We always had great retention and recruitment and great outcomes, but not at this level. This was by far, and we have done focus groups, interviews with the participants. We're currently doing something now, and they just love the intervention, and they continue to see benefits years later. Again, we had more women than male participation. Hula is although traditionally men dance hula, and there's a lot of halal dedicated to kane. We somehow just didn't get the number of men we wanted to get to participate. But again, this is not an uncommon issue and not that specific to just this study. Just want to mahalo, recognize the funders and so forth. And I'll stop there and take any questions or thoughts you may have. Mahalo nui.
Awesome. Mahalo, Dr. Kaholokula, for sharing this really awesome research project, but also that, it really involved our community in all stages of the research and integrating cultural knowledge, cultural protocol with scientific inquiry. So just wanted to open it up to anybody. If you folks have any questions, feel free to unmute and ask your question, or feel free to put it in the chat if you have any questions. Any questions? I guess I'll start off. I guess, one question. Oh, sorry. we have a hand raised. Yeah, go ahead. We have Dr. Tangon here.
Yeah, mahalo. I don't know if you can see me. I can only see the slides still right now, but mahalo Keawe for the wonderful talk. It's always good to hear about the really critical, important work you're doing. So I guess maybe, yeah, on the topic of Kane, yeah, maybe no surprise that there are less Kane involved there. I know something you and I and others have worked on for a while.
Yeah.
But could you talk a little bit about the different results? I mean, how are their numbers for the few that were involved, as opposed to the wahine? And if you got any qualitative kind of data or insights from some of the interviews or top stories with them about what is perhaps most effective for them as Kane.
Yeah, no, that's a good question. The first question was whether or not we saw differences in the outcomes based on whether they were Kane or Wahine. We actually didn't. We looked at the stratified or gender, stratified by gender, looking at whether or not we saw different results. We did not. In fact, as most cases, we saw a slight higher, little bit, not significant, but men in general, traditionally, when doing these kind of lifestyle interventions, reach the outcomes, at higher levels than women traditionally. So weight loss, to get more weight loss. Blood pressure, slightly more improvement, but not that much different. So not really anything to talk about. So no, in that regard. What we were seeing as far as, I'm sorry, what your other question, Kavika, was really around.
I mean, if you guys, in any of the follow-up interviews or
Yeah,
debriefing
okay.
talk story, if there are any things that they said for them was particularly important about how they were able to achieve those outcomes in the study.
Okay. Yeah. No, we've done extensive. Actually, so we went out after the study and we did a report to the community. So we flew to Maui, we flew to Hawaii Island. We had 2 on Oahu, 1 in Waianae, hosted by Waianae Coast Comp, and 1 over here at Jabson. The Jabson one, we had over 100 people from the community attended. So basically, we wanted to report out the findings before we publish to our communities. And they actually ended up doing the whole hula, everything for us. And so we had it was like basically a ho'ike, yeah. And so a lot of opportunities there to hear testimony, and they provided testimonial around their participation. And on top of that, we've done focus groups and interviews, and we continue to do, because now we're looking to use hula to address the issue of Alzheimer's and other related dementia in Native Hawaiians. And what we're learning is that, again, everyone's consistently said that they really love the hula. It's really about, the cultural and the social connectedness. So Pili I Ke Kanaka, right, is a big one. So that actually comes out the biggest, the opportunities to interact. What's interesting, Kavika, is in our pilot project, even in this project, we're slowly looking at the other measures, is that one of the things we find is that there's a significant reduction in perceptions of racism for those who participate in the hula, but not the control group. And as you know from our other studies, we connect racism to hypertension as it's a social stressor over time that can lead to problems. But what we're finding is that, and we're assuming that because it's a cultural-based program, when you're around others with a similar value system and things, somehow it serves as a support or a buffer, maybe. Because of course, things not changing in the outside world. We're not influencing that. We're only influencing what's happening within our setting. But somehow it's having a positive social cultural impact on our participants. And they're saying this. They're saying that the social and cultural factors are the things they believe are the most beneficial. In talking with national experts around hypertension, they too would agree with our participants and myself that it's not the physical activity that's really getting these improvements. He too, this one person, is a physician and does a lot of consulting nationally. He calls it the secret sauce we have. He too doesn't think it's the physical activity. He thinks it's the social and cultural factors. And So everything's kind of aligning there, Kavika, and that's why I'm a now big supporter of looking at other cultural practices uh, as the to either as the foundation for an intervention to address a concern in our communities, or to leverage as part of an intervention to address concerns in our community.
And then I guess the follow-up, if you have the answer that we're always looking for, if you know how to get more men out, are there specifically different activities tailored, something more, other kinds of Kane-centric activities you think might appeal more and some other design, or if you heard anything else in those presentations on the part of the Kane who didn't participate in terms of things that they would have wanted to have seen that might have got them out?
Yeah, Lua has come up a lot of times. Lua, canoe paddling, are the two things coming up a lot with Kane. What's interesting, Kavik, what we did see though is the younger generation of Hawaiians. So we had mainly older folks because hypertension develops a little older in age, right? But for those who are a little younger, under 30 or just reaching 30, just over 30, we had a few that did have hypertension participated. What we're finding is for the hula, the younger Hawaiian Kane were more likely to participate. So definitely, I think that group, and when you think about what hula means and what all the other stereotypes, it makes sense, right? For the younger generation, the older generation has a different perspective, perhaps, of men dancing hula and so forth. But yeah, so I think younger Kane, it's okay. I think we can do something there and can be leveraged for other things. But I think, yeah, looking at Lua or other practices is for our Kane would be worthwhile.
Did you hear if any of the men's ideas about hula changed as a result of participating in it? Were you guys collecting any of that information?
No, I don't think we saw any change because the ones that participated, of course, were already okay. They wanted to participate. So I don't think they changed significantly. And then just let you know, we made strong efforts to over recruit for Kane. I mean, I was personally reaching out to Kumuhula, Kane, Kumuhula, going out to certain areas, and we got some because we obviously ended up getting a good number of Kane, but not quite the number we wanted. We wanted to get to more of a 60-40 balance. Mahalo.
Mahalo. Are there any other questions? We just have a few mahalo in the chat box. Great presentation. It is great to see positive outcomes of a culturally grounded program. Well, one question that I had, and you kind of talked about it, was other activities such as Lua and Hoiva'a. Definitely that in itself has its own cultural grounding and core, separate from hula. But my other question was, are there future plans or research or directions from this Kaholo project?
Yeah, so as I kind of mentioned, I guess, but not quite, we were actually we're modifying our hula, not even modifying, just now adapting our hula intervention to address the issue of Alzheimer's and other related dementia in our communities. So we're seeing earlier onset of dementia in indigenous communities and Native Hawaiians as well, and Pacific Islanders. So we're actually currently got funding for doing that. And so with that study, how it's going to be a little bit different than this one is we're actually intensifying the cultural activities, the language and so forth, to get cognitive exercise, to get the brain activated more. So we're actually currently in the development phase. We're probably going to start recruitment on that. The other thing is that now we're having colleagues from other indigenous communities thinking about how they can use their cultural practices, their dance forms, for example, in a similar way, and so forth. So we're seeing some movement around that, right? And sharing those protocols that we did to get to that point to be able to do that. I'm encouraging. I think there's someone right now on this webinar that I'm encouraging to apply for some pilot funding that we have through our PICO Center to maybe look at another cultural-based intervention. This one would be for more of a mental health or behavioral health. But definitely, I think there's so much opportunities that we can take advantage of to to really show the value of our cultural practices for health promotion in different ways.
Awesome, thank you. I think it definitely would be interested in, even for our Pacific Islander cousins to, you know, to use this model that you folks have developed for their own cultural and health and well-being.
Yeah. I should mention that in our pilot trial, we had actually Chukis as well as Native Hawaiians participate, and we actually found similar results, significant changes. And when we looked at whether or not they were different, there were no difference, which is interesting, right? So a Hawaiian-centric intervention was actually relevant to Chukis. In fact, the Chukis group that participated, when we had a report to the community for another project, they actually came and danced hula for the community people that were there that we were doing this for. And so it has, I mean, it makes sense, right? You know, either you're going to take one Haole-based activity that from 4,000 miles away and ask them to engage in it, or you're going to find something closer to home in the Pacific, right? That has at least a value system that is relevant and that you can somehow apply in meaningful ways. So I do think, although I do think we need to find specific Pacific interventions for specific groups because they got awesome dances and other things they can do. But, you know, in the meantime, here in Hawaii, we have this to offer people that I think benefits more than just Native Hawaiians. Mahalo, Tatiana, for your comment.
Definitely, we got to make it specific for our people.
Yeah, definitely. I like that. Ocean connects us, not divides us, so makes sense. Yeah.
Okay, so I just want to mahalo again. Mahalo, Dr. Kaholokula, for taking time to join us today. Mahalo for everyone here for attending. Also want to recognize Dr. Kavika Tingan, who is part of our Hui Aina Pilipili faculty. And I would like to mahalo Kale Tuitupo for helping with this webinar. I hope you all folks received some thought-provoking aha moments during our presentation with hula and how it can be used as an intervention for our health and well-being. Again, this presentation will be recorded and will be publicly available. So be sure to check your email. We have another exciting lineup coming up next semester. So be sure to check your emails. Mahalo nui and have a great day.
Aloha, everyone.